Welcome and good afternoon, everyone. I am Catherine Brookman, Associate Director, Knowledge Transfer and Exchange, and on behalf of Dr. Jack Callahan, Director of the Center of Research Expertise for the Prevention of Musculoskeletal Disorders, or CRE-MSD as we are more commonly known, we'd like to thank you for joining us today for this free webinar, and we extend a warm welcome to all our client patient handling community of practice members who have joined us today. We are grateful to the Ministry of Labor, Training and Skills Development for our funding, which supports the delivery of these webinars, and to our presenters who provide their expertise. We ask that you keep yourself muted for the duration of the webinar as a courtesy to the presenters and all participants. The format of today's webinar is as follows. The presentation will be given, after which time we will have 10 to 15 minutes for a question and answer period with our presenter and her co-authors. During the question and answer period, we ask that you type your questions into the chat box. The chat box can be pulled up on your screen by selecting the chat icon in the control panel that appears near the bottom of your screen. I will relay these questions to the presenter or a similar question should we have duplicate themes. Should you have a pressing question or issue such as a technology glitch that cannot wait until the end of the presentation, please type this into the chat box and we will do our best to address it right away. This webinar will be recorded with the recording being made available to you on our website along with the presenter's slides shortly after today's webinar. You will also be sent a link to an evaluation. Please fill this evaluation out as it will assist us in the future delivery of our webinars. It also includes a few new questions such as your preferred time for these webinars. Thank you so much for joining us today, and remember to watch the CRE-MSD website and the MSD prevention site for new resources and events, including a case study contest on musculoskeletal disorder prevention ergonomic interventions. Submissions due August 31st. Now it is my pleasure to introduce to you our presenter. Amanda Calford is a student researcher in the Occupational Biomechanics and Ergonomics Lab at the University of Waterloo. Her research focuses on the implementation of assisted technology in emergency medical services to decrease the injury risk of paramedics. Her co-authors are Dr. Taylor Cleworth, Assistant Professor at the School of Kinesiology and Health Science at York University, and Drs. Andrew Lang and Stephen Fisher, Associate Professors in the Department of Kinesiology and Health Sciences at the University of Waterloo. Now over to you, Amanda.
Thank you, Catherine, for that introduction. Today, I'm excited to share my research with you on exploring the efficacy of portable lift assist devices to reduce exposures compared to a manual lift. A bit of background on the problem. Patient lifting is a common task in emergency medical services, and it's been proven to expose paramedics to extreme postures, as is highlighted in these images. Patient lifts have also been shown to exceed the National Institute for Occupational Safety and Health's recommended weight limits by 2.3 to 3.5 times. The recommended weight limit is the max acceptable load that healthy workers can lift without an increased risk of musculoskeletal disorders. This high prevalence of patient lifts in EMS contributes to the high rate of injuries among paramedics, who are injured at 3 times the national average of all occupations in the United States. Lift assist calls have been identified as to be increasing by our industry partners at Niagara EMS. Lift assist calls occur when emergency medical services are called to lift someone who has fallen or is stuck in an undesirable position. They will call 911 to be lifted into a recovered position, and oftentimes there's no medical intervention, so there's no transport. Lift assist calls can happen in the community or in long-term care and other institutions where there is a workplace zero lift policy, meaning if someone has fallen, staff at the long-term care or other institution cannot lift that person back up to a recovered position, so EMS may be called to lift the fallen resident. Lift assist calls are so prevalent that Niagara EMS has come up with a team to intercept these calls. They call it the Falls Intervention Team or the FITS team, and it is an SUV rather than an ambulance, staffed with one paramedic and one occupational therapist. They will respond to lift assist calls and use portable lift assist devices to recover a patient. And they also complete follow-up visits to try to reduce repeat callers, which is a problem with lift assist calls that people are often calling EMS more than once. If they've had a fall once, they're likely to call EMS again for the same lift. Emerging portable lift assist devices have the potential to decrease the number of manual lifts completed by paramedics. These devices eliminate the physical lift and administratively may reduce the number of crews necessary to lift bariatric patients, where if a team of EMS arrive at a scene and based on patient demographics, they may call for a second crew or for fire to come and help them complete the lift. If portable lift assist devices decrease exposure associated with completing a lift, they could also be used in long-term care and other facilities. They would comply with workplace zero lift policies and could be used in situations where the large mechanical lifts currently in facilities can't be used due to the space available, such as in washrooms, beside the bed, or in tight hallways. If they could be implemented in long-term care, this would also be beneficial for patient experience, where they wouldn't be waiting for EMS, where if a fall occurs and EMS is called, that person is lying on the floor until EMS is able to respond. It would also decrease the outsourcing of physical exposure to paramedics, where long-term care staff can't complete the lift because it is dangerous, so EMS is called in to do the lift. And administratively, it may decrease the burden of lift assist calls on EMS. So our project objective was to evaluate the efficacy of the Elk and Raizer lift assist devices relative to a fore-aft lift, which is a manual lift, for lifting a person from the floor to a stretcher, considering user perception and biomechanical exposure data. This project objective was decided on in collaboration with our industry partners. To test the devices, we recruited 21 participants from Niagara EMS in Ontario, and we scheduled the participants in pairs to facilitate two-person lifting. We had 3 lifts: the manual fore-aft lift, the Elk lift, and the Raizer lift, and participants completed each lift twice, once as the lead lifter and once as the assistant lifter. Pictured here is the manual fore-aft lift, where the person lifting the torso is the lead lifter and the person lifting the legs is the assistant lifter. And for the technology facilitated lifts, the assistant lifter is supporting the patient on the device, while the lead lifter is operating the device. This study took place at a Niagara EMS training facility, and participants lifted a trained actor who weighed 49 kilograms and had a height of 1.65 meters. The 3 lifts were completed in block randomized order, where participants always completed the manual fore-aft lift first to benchmark the other lifts against. Here I have a video of the manual fore-aft lift. In this situation, we've told the paramedics that this person has fallen, no injuries are suspected, and they just need help returning to a recovered position. To complete the manual lift, the paramedics approach the patient and sit them up. The lead lifter is behind, and they are going to grasp both the forearms of the actor and cross them over her chest. The assistant lifter will grab the legs, and on 3, they will lift the actor. And they're going to complete this lift to the stretcher, where she is now in a recovered position. For the next lift, the Elk, This video has been sped up 6 times to make it a comparable length to the manual lift. The Elk is a pneumatic device. The gray cushion is going underneath the actor right now. It is important for the actor to be centered on the device for stability during the lift. So you can see they're making some adjustments to get her centered on the device before the lift occurs. There are 4 sections to this device and 4 hoses go 1 hose to each section, and then 1 hose to the battery pack. Once the device is set up, they sit up the actor and support her from behind as the device inflates. There are 4 sections of this device. 3 sections need to be inflated to transfer the person off the device, and a 4th section is available depending on the patient height. So here we can see they use 3 sections and then they just assist her to the stretcher. For the Raizer video, this video has been sped up 4 times. The Raizer has a seat that slips underneath the legs, so they'll bend her knees to push it underneath, and there's a seat belt on this base. Once the seat belt is done up, there's then 3 pieces per each side, 2 legs and a back support piece. To get the back support piece underneath the person, she is slightly rolled by the partner while the other participant gets the back piece underneath. When all pieces are connected to the device correctly, it turns itself on. And while the device is being used, we're supporting the actor from behind, just supporting her neck during the lift. You can stop this lift at any height and bring the stretcher over to then assist her to a seated position on the stretcher. So we had 2 biomechanical outcome measures. We collected electromyography, which is the electrical signal to the muscles, and we processed this in such a way to represent muscle activation as a surrogate measure for effort, where more activation represents more effort. EMG was collected bilaterally from the biceps and the lower erector spinae, so that it's a muscle in the arm and a muscle in the low back, to track muscle activation required for the lifts. Rating of perceived exertion, or RPE, is a 6 to 20 scale where participants can rate how hard they felt they were working during the lift, and it was collected after each lift. You can see some benchmarks on the scale from 6 to 20, going from no exertion to 20, which would be maximal exertion. Lift assist device facilitated trials were segmented into 3 tasks, and the muscle activation were windowed to these tasks. We chose these 3 tasks by reviewing the videos of people completing these lifts, and the 3 tasks were device retrieval and setup, which involved getting the device underneath the actor, device operation, and transfer to the stretcher. EMG from these trials were compared to the manual trial to see if lifts completed with the devices increased or decreased the muscle activation required to complete the lift, and we calculated a percent activation of the manual, where 100% would be equal activation, less than 100 would be a decrease, and more than 100 would be an increase in muscle activation compared to the manual lift. We also had 3 perception-based outcomes. We used the System Usability Survey, which measures usability and learnability, and asked questions like, I thought this system was easy to use. Participants would rate their agreement with the statement from strongly disagree to strongly agree. The SUS was then scored with possible scores ranging from 0 to 100, and we can see some benchmark scores that represent average and excellent usability to give the scores some meaning. An exit interview was conducted with participants, probing participant perception of the devices and benefits and barriers to using the devices. And we also collected user preference, where participants were asked of the lifting methods used today, which was your favorite. So getting into some results, rating of perceived exertion was significantly higher for the lead lifter during the manual fore-aft lift relative to using an assistive device. So on the graph here, we can see that the fore-aft had a significantly higher rating of perceived exertion than the Elk and the Raizer. There was no difference between the devices, but both decreased the rating of perceived exertion compared to the manual. On the y-axis, we have the rating of perceived exertion from 6 to 20, from no exertion to maximal exertion. And rating of perceived exertion did not change for the assistant lifter across different lift types. So getting into why we think we saw these changes in the rating of perceived exertion, our EMG, that's our muscle activation, showed lift assist devices maintained or decreased the muscle activation required for each lift. So I have a chart here with some of our results. It's a little bit busy, so I'm going to take a moment to orient you to our chart. So this chart is for our lead lifter muscle activation. We have the Elk and the Raizer, since we compared to the manual. That's not on the chart since we're looking at changes from that manual condition. We have our two muscles, so the left and right bicep, and the left and right SB, that's the erector spinae muscles. The first three columns are the max muscle activation, and the last three columns are the average muscle activation. Squares in gray represent no change. We also have our three tasks within both the max and average conditions: device setup, device operation, and transfer. Gray tiles represent no change from the manual condition. A red tile with a plus indicates an increase in muscle activation and effort compared to that manual trial. And green tiles with a minus sign represent a decrease in muscle activation. So from this chart, we can see that there was two increases in muscle activation, and both were in the right bicep during that first task, device setup, in the max muscle activation. However, overall, we see that muscle activation was on par or decreased compared to the manual condition. Next, I have this same chart, except now we're looking at the assistant lifter muscle activation. So we have the same Elk, Raizer, muscles, and tasks. And we can see in this chart that we only observe decreases in muscle activation or maintenance. So this supports our findings in rating of perceived exertion, where participants felt that the lifts completed with devices had less exertion compared to the manual lift. We found no significant difference in the rating of perceived usability from the system usability survey. So we can see here that the fore-aft, Elk, and Raizer all had similar usability ratings. All three lifts were above that average usability threshold from the system usability survey, and none of them were above that excellent usability threshold. These results, while there's no significant difference, are positive for the devices. After reviewing the exit interviews, it was clear that the manual fore-aft lift was seen as extremely simple, familiar, and easy to do. The devices were novel to most participants and do come with a slight learning curve, and they also add some complexity to the lift, where instead of going up to someone and manually lifting them, it does add a few steps of assembling the device and using the device. So while we don't see a difference in usability, this is actually a good thing, where these devices and their added complexity did not decrease the usability associated with the lift. The error bars on the screen represent the interquartile range, showing the spread of responses from the 25th to 75th percentile. From this, we can see there is more agreement in responses of the Raizer, where that interquartile range doesn't span as far as the Elk did. In addition, the interquartile range did not cross the average usability benchmark, which both the fore-aft and the Elk, we can see their interquartile range cross that average usability line, where the Raizer did not. And participants preferred having access to a lift assist device rather than performing the manual fore-aft lift. So from this chart, we have the frequency of preferred lift type, where we asked participants which lifting method was their favorite. And this is a frequency chart, so we can see 2 people preferred the manual fore-aft, 6 people preferred the Elk, and 12 preferred the Raizer. Significantly more people preferred the Elk and the Raizer compared to the fore-aft. There was no statistically significant difference between the Elk and the Raizer. However, we can see more people reported the Raizer as being their preferred method. Finally, from our exit interview, we transcribed everyone's exit interview and performed a thematic analysis, which revealed our two main themes: benefits, devices as an asset, where this theme saw the devices as a beneficial tool for the paramedics when it comes to lift assist calls, and barriers, devices as a liability, where this theme is the device as a liability for paramedics when it comes to lift assist calls. And we can see the kind of sub-themes that went into these overarching themes. Getting into the benefits, we had three sub-themes: promotion of career longevity, improved patient experience, and ease of execution. For promotion of career longevity, participants reported decreases in physical exertions associated with completing a lift, and both devices were identified as helping with lifting larger or heavier patients in comparison with the manual. That's where paramedics really saw these devices as beneficial, is when lifting heavier clients. They also identified a decrease in risk of injury, as both devices essentially eliminated the physical lift, and decreases in mental stress and anxiety. The paramedics reported high stress going into lift assist calls due to fear or anxiety regarding possibly getting injured and even potentially suffering a career-ending injury when responding to calls where they need to lift people. So having access to a device was identified to decrease the stress associated with responding to these calls. For ease of execution, our kind of bullet points that went into that were easy to use, easy to set up, minimal effect from time regarding usage, and easy to clean. Paramedics reported these devices with easy setup and a low learning curve. And the minimal effect from time regarding usage was really important as a theme that emerged from these exit interviews, where if you think back to those videos I showed you at the beginning of the presentation, the Elk video and the Raizer video were sped up 6 times and 4 times respectively to make them a comparable length to that manual lift video. So clearly the devices take a little bit more time to use. However, paramedics reported that they would always take the time to use these devices when responding to a lift assist call, that the increased time is worth it due to the increases in safety, both for themselves and for the patient, where the paramedics don't have to complete the lift, so their risk of injury is lower, and they perceive the devices as being more comfortable for patients, so they would always take the time to use these devices. They also identified the devices as easy to clean, with hygiene being especially important during the COVID-19 pandemic. And the fore-aft lift was found to be unhygienic, where you are in that person's space and there's a lot of contact between you and the person you're lifting, even outside of COVID-19, just for other concerns with hygiene performing these lifts. And our last sub-theme was improved patient experience, where devices provide bodily support for the patient, and the patients don't like getting lifted manually. That's a lot of contact with the person, and it's not a gentle procedure when you're manually getting lifted. So the devices were perceived to improve patient experience. And the devices were also identified to be able to be used on patients of different characteristics, such as varying heights, weights, and ages. For improved patient experience, these were perceived increases in patient experience, as we didn't test patient experience in this study. However, we did have 5 participants who had been involved on the falls intervention team and had access to the Elk and Raizer when responding to lift assist calls. And they reported that people really liked being lifted by the devices, that it was more comfortable for them, and people enjoyed that experience. One participant in particular worked on the falls intervention team and then went back to working on a normal ambulance. And he stated now that he's on an ambulance responding to lift assist calls, he'll show up to the scene to lift someone, and people will be really upset if they have already been lifted with either the Elk or the Raizer. They're questioning why they don't have access to that, and people get upset when they have to perform the manual lift, as they're afraid of getting injured from the manual lift, and the devices were a better experience for them. So they prefer being lifted with the device compared to a manual lift. Getting into the barriers that emerged during our exit interview, we had our three main sub-themes, which were changes to the process, administrative obstacles, and situational dependence. For changes to the process, there's different exertion with these devices, where there's slight changes to the lifting process, including different required movements, such as rolling the person to get the elk cushion underneath and supporting them from behind during the during the lift, as well as carrying the device onto the scene, where the Raizer in particular is a little bit of a heavier device. A learning curve was also identified, although it was identified by most paramedics that the devices were very easy to learn. Some training would still be required before they would go out to use them. For administrative obstacles, liability concerns, money and maintenance, and device distribution and accessibility emerged as contributing to that theme. Liability concerns were actually identified based on conversations with our research partners, Niagara EMS, as not being a concern for paramedics. However, this might be a concern in other situations, such as long-term care, where strong standard operating procedures may be important to protect the liability of workers when using these devices. For money and maintenance, these devices do have an upfront cost, and the maintenance of these devices will have a bit of an ongoing cost, as well as installing charging devices and having access to charging. And device distribution and accessibility, paramedics were concerned with how many devices they would have, which ambulance should get them, and if different regions should have more access to these devices on the trucks. Our last sub-theme, situational dependence, was about the use of a device versus a manual technique, and it's extremely dependent on the situation, as all devices have their benefits and barriers in certain situations. Contributing to this theme was the environment, and the two main concerns were the space and the floor, where the devices, although they don't require much space if we compare it to the large mechanical lifts currently in long-term care, they do still require some space to be used, and they might not work with some falls occurring in the bathroom, such as a fall between the toilet and the bathtub, which was identified as a common place for falls to occur. And device use was dependent on the floor characteristic. For example, if you're on gravel, uneven surface, or grass. And participants identified the fore-aft lift as useful for lifting in tight spaces. And our final kind of sub-theme was patient condition, which was emergence level and chronic versus acute injury, where the devices were going to be used in non-emergent situations. When asked if there was any situation where paramedics would not use this device, they responded with an emergent call. However, these devices were never intended to be used in emergent situations. They're more for lift assist calls where medical intervention is not required. It was also identified that the devices were more suitable for patients with chronic injuries or pain, as the device is more gentle during the lift. For example, patients with a shoulder injury, the fore-aft lift might aggravate that injury, and the devices were just more gentle. And by having Niagara EMS involved in this study, barriers identified can be planned to be overcome in the implementation of these devices, where since we've already identified these barriers, we can plan to address them before the devices are introduced to the service, instead of introducing the devices and retroactively going back and addressing barriers as they emerge. Overall, biomechanical exposure decreased with the use of a lift assist device. We saw this with decreases in muscle activation from the EMG and rating of perceived exertion. We would expect to see further decreases with a heavier actor. Again, our actor weighed 49 kilograms. During that manual lift, if we assume their weight was distributed equally between participants and equally between limbs, this would be a weight of 12.25 kilograms per limb, where the Raizer battery / seat weighed 9 kilograms and the pieces weighed 4 kilograms. So they were lifting a similar load with the manual lift and just lifting the Raizer as a device. So if we had a heavier actor, we would expect to see further decreases. I had one participant report a rating of perceived exertion of 6, which was no exertion for all the lifts. So it's expected that if they were lifting a heavier actor, that the manual lift rating of perceived exertion would increase more than the device-facilitated lifts, since the device-facilitated lifts remove that physical lift. And the barriers revealed in exit interviews can be addressed with strong administrative controls. One of the barriers that was identified was changes to process, which included different exertion and learning. And this is where training of how to complete these movements safely, as well as how to use the devices, can overcome this barrier. Administrative obstacles included liability concerns, which we confirmed with EMS was not actually a concern, but clear standard operating procedures of when to use the devices may be important in other settings, such as long-term care. Money and maintenance, these devices do have a cost, and this contributed to those administrative obstacles. However, these devices did decrease exposure, so we would expect to see a decrease in injury, where the devices may pay for themselves with decreased injuries. However, that was not explored in this study and is kind of a next step. For the environment and patient condition, this is again where standard operating procedures on when to use the devices and training so paramedics can identify what situations the devices are appropriate for would be important in the rollout of these devices. From our perception-based outcomes, devices were perceived to be easy to learn and use, decrease injuries, and increase career longevity, and increase patient experience, all of which are important for adoptability. I have some citations here just stating that these factors were really important for the use of interventions, where if an intervention is introduced, even if it's going to decrease injuries, without these other factors, they still might not be used. So some key takeaway points from our research. Paramedics perceived lifts to be less demanding when using a lift assist device, and devices were perceived to increase patient comfort and experience, which is really important for adoptability if and when these devices are purchased. And paramedics preferred access to a lift assist device rather than performing a lift manually. The Raizer was preferred by more, but you may want access to both devices if feasible or possible, as one device was not seen as an answer to all situations. For example, the Elk has a higher weight limit, so it could be used in situations where the Raizer couldn't be, even if the Raizer was preferred more. And training and when to use guidance are important to support adoption, and change in management process may be important to help paramedics move away from their tried and true fore-aft lift method. This came up often in the exit interviews, where if paramedics were having trouble deciding which lifting method was their favorite and they were trying to justify why they liked the fore-aft, their reasoning was, it's what we're used to. We do this every day. It's our bread and butter. So supporting paramedics in the transition to these lift assist devices would be important in the rollout of these devices. So some next steps from our research team. We are submitting our paper to a peer-reviewed journal for publication to continue sharing our results with stakeholders, so look out for that. Different populations, for example, long-term care staff, could be considered. When we first started this study, our intention was to collect long-term care staff. However, some issues with recruitment and then the COVID-19 pandemic caused us to pivot and focus on the paramedic population. An intervention and cost-benefit analysis could also be considered, where once these devices are purchased, we can follow them in the field to see if they are effective and if they do have decreases on injuries like we would expect. We also have future work planned evaluating other products aimed at decreasing injuries during patient handling tasks. So with our research partners at Niagara EMS, they have identified lifts from floor, lifts from confined space, and lateral patient transfers as 3 tasks most contributing to the injuries that they are seeing. So we're going to look into these 3 patient handling tasks and different technology that's available to try to decrease exposure associated with these tasks to try to decrease injuries. As I'm finishing up, I would like to do some quick acknowledgements. First, to CRE-MSD for both the opportunity to speak today to share our results, as well as for the funding for this study. Our industry partners at Niagara EMS, who helped us design this study to make sure it was relevant to end users, and also provided the facility for us to complete the study. The Occupational Biomechanics and Ergonomics Lab at the University of Waterloo, I would like to thank my lab mates for their support during this study. And finally, the research team, Daphne Ho, Dr. Taylor Cleworth, Rick Farron, and Dr. Andrew Lang, as well as my supervisor, Dr. Stephen Fisher. A thank you to them for their contributions and support during the study. That concludes my presentation, and I look forward to answering your questions.
Thank you so much, Amanda. And we do have a lot of questions here. Hopefully we'll get through all of them. The first question is, how much training did the participants receive on the use of each piece of the lift equipment prior to conducting your research?
Right. So most paramedics, as I stated, were unfamiliar with these devices. To overcome this, when participants contacted me interested in participating in this study, I sent them training videos on both the Raizer and the Elk. These training videos were reviewed on the day that they came to participate. And to try to minimize the effects of learning during the trial, we conducted some practice trials using the Elk and Raizer before collecting data, where participants used the devices until they reported feeling comfortable. And I was there to check that they were doing it correctly. So we had the training videos, which were sent to them before coming in, reviewed in person where they could ask questions, and they had training familiarization trials that I could validate since I was familiar with using the devices.
Great, thank you. Were the tasks attempted with an actor that was fully dependent on the paramedics for movement?
So our trained actor, we asked to not help the paramedics. She was instructed that she was not going to resist them, but she also wasn't going to help them to be as close to dead weight as she could. So we tried to simulate this as much as we could. However, there are some limitations with completing the lifts in a in a controlled environment where we're instructing the person rather than someone who might have less trunk stability than the actor that we used.
Okay. What is the weight of the devices themselves? And what we're trying to get at here is, what is the MSD risk to the users when loading or unloading the device?
The Raizer device, that seat that kind of slid underneath the legs, that on its own weighed 9 kilograms, and the pieces weighed 4 kilograms. The pieces were in a backpack, so it could either be carried in the arm or secured on the back while the device was to be carried. The Elk, I'm not sure of the exact weight, however, it was a lot less. That cushion was pretty negligible, and the base, I would, this is an estimate because I don't have that information in front of me, but I would say around 2 or 3 kilograms. It was much lighter. So we asked, this was something that came up with paramedics, was the weight of the devices, where they preferred the Elk a little bit more because it wasn't as heavy, but the Raizer wasn't seen as too cumbersome to kind of take away from all of the other benefits that the device had.
Okay. Are you aware if the devices are suitable for outdoor use, such as rain or snow conditions?
As I'm aware, I've seen the Elk used outside. Personally, I have not seen the Raizer. That might just be a limitation on my familiarization with it. However, it does have those legs that need to be able to slide on the floor, so I do see that being a bit of a concern in outdoor situations. However, I have seen the Elk used outside.
Okay. And we did have a comment that the Raizer is used mainly for indoor use.
Yes.
Would there be a benefit if these devices are promoted at locations where falls are frequent, such as retirement homes, long-term care, to reduce the need for EMS or to have the patient client lifted prior to EMS arrival?
Yeah, that was seen as one really big benefit of these devices. Right now in long-term care, large mechanical lifts are common. However, it's been criticized that it can't be used in tight spaces, such as if a fall happens between the bed and a wall, or in a bathroom, or down a narrow hallway due to space concerns. So long-term care, to comply with that zero lift policy, if their device can't be used for space considerations or other reasons, they're calling EMS. Since these devices at this point have been shown to decrease exposure and could comply with zero lift policies, if the devices were available in long-term care and long-term care staff could complete the lifts, this would be beneficial for two main reasons. First, to decrease the burden on EMS of lift assist calls to long-term care. Where in long-term care, healthcare professionals are already in the area, so if they had access to the correct equipment, they could complete the lift without calling EMS. When EMS responds to a lift assist call, that takes one crew off the road to respond, who then can't respond to other calls that might be more important. The other pro of having these devices available in long-term care would be to increase patient experience. Where if a patient falls in long-term care and they need to call EMS to get them lifted, the patient is laying on the floor until EMS arrives. And a lift assist call is a low priority for EMS, so they may be laying on the floor waiting for a long time, which is not comfortable for that person. Also, literature has looked into kind of this, they call them long lies, where if someone is laying on the floor for more than 60 minutes waiting for EMS, they define that as a long lie. And 50% of people who experience a long lie will die within 6 months, regardless of their health status or why they had fallen in the first place. So eliminating that time where someone is laying on the ground would improve the patient experience and kind of get rid of that risk of mortality that it's associated with prolonged periods laying on the floor waiting for someone to recover them.
Okay, thank you for that. A little bit scary. What if the patient fall caused some injury to spine in which flexion of the spine needed to be avoided? Is this possible with these devices?
So this is where the devices likely wouldn't be used. They're designed for non-emergent calls. And as we saw with the Elk, you're doing a roll to get the person onto the device, which wouldn't be possible during a spine injury. And even with the Raizer, there is that slight bit of roll to get the back support piece underneath, as well as the movement associated with using the device. So if an injury like that is suspected, these devices aren't intended to be used. I have seen in Europe, where the elk is a little bit more common, paramedics have sometimes used the device underneath a backboard to help lift the backboard to a more ergonomic height to then complete a lift. But to lift someone with an injury is not how these devices were intended to be used.
Okay. Can you just go over again why the razor was preferred to the elk and why did people not like the elk?
Yeah, so there was a few reasons, and it was really dependent on the person. I think the main reason that the Raizer was preferred was that back support that is included, where when responding to lift assist calls, the paramedics reported that you're not responding to someone who's in full health, because if they fall, they're likely able to get up on their own. So you're mostly responding to people who have some sort of mobility problems or neurodegenerative problems that is affecting their health. So if they respond to a call to lift someone with limited trunk stability, that back support on the Raizer was seen as really important. As well as lifting heavier people, the supporting from behind on the elk during the lift would still be some exertion, where the paramedics would be responsible for keeping that person balanced during the lift. So the back support was really important for different patients, especially that trunk control piece kept on coming up. And I know from speaking to people in long-term care, that was a concern they had with the elk as well, was people feeling stable on the device and being able to maintain their balance. And yeah, that was really the main reason, was just the patient comfort. The elk was really functional, like it could be used in more situations because it did have the higher weight capacity. But the patient experience really came in with the Raizer, where they found more people would feel safe on the Raizer and it would take less effort from them to support the patient during the lift.
Okay, thank you. Were there inclusion or exclusion criteria for the participating paramedics or occupational therapists?
Yeah, our inclusion criteria was currently being employed by Niagara EMS, participating in full service. So if anyone was participating in modified duties due to injuries, they were excluded, and they needed to be responding to calls at the time as well.
Okay. Did you find differences in responses of the exit surveys for those with more or less experience in the industry? I'm not sure if you controlled for that.
That's not something we controlled for. I found with our population, it did tend to be younger paramedics who came in and contacted us to participate in the study. I was expecting the younger paramedics to maybe not see the benefit of these devices as much. However, all of them were aware of the high injuries in their field, and a lot of them mentioned, while it's not a concern for them right now, the increase in career longevity was really important to them, and they really found these devices as being beneficial. I did have one of our older participants did prefer the manual lift compared to the fore and aft, or sorry, compared to the elk or the Raizer. And that again came down to it's what they've been doing for their entire career. It's what they're comfortable doing. They've kind of made it this far using that method. So just kind of the willingness to change and see things from a different way was something that came out. We didn't have too many older participants, but it was something that I did notice kind of um, what's the word? Anecdotally.
Okay, great. Um, do both lifts require two people to assist, or could one person complete the task? So you had a paramedic and an OT. Could it be done with one of these lifts or both with just one person?
Yeah, both of these devices are designed to be used by one person, so they both should be able to be completed by one person. This is where conversations with our industry partners, who would be the end users of these devices, were important. Paramedics would never respond to a call on their own, even if it is a lift assist call. They would always arrive in a pair to use them. And we did have some conversations with people from long-term care at the beginning of this study when we were hoping to recruit from a long-term care population. And they also identified that lifts would be done with two people. So the devices are designed to be used by one person, but to comply with workplace policy, it sounds like they would likely be used in pairs.
Thank you. Did the paramedics indicate whether or not, or the OTs, whether or not the clients were uncomfortable with them using a lift assist device, or were they just glad to get the lift?
The paramedics mostly reported just positive feedback from patients with the lift assist devices. It was really telling that one individual who worked on that falls intervention team and then went back to the ambulance, he said that he had people in tears being afraid of the manual lift, where when you brought out the Elk or the Raizer lift assist devices, his direct quote was, "It's all hugs and kisses, and they're all happy when they see that you have these devices for them to use." There was more concern around that, again, perceived concern with the elk, where it is a little bit more unstable. The paramedics who had used them said that when they use these devices, they would often put a chair beside them so that the paramedic is supporting them, but the person being lifted still has the opportunity to get some support kind of independently from the chair to increase their comfort. But everything that was reported was people really loved these devices and were really happy to be lifted by them. And it got rid of some concerns associated with that manual fore-aft lift.
Okay. Do you know if lift assists are carried out more in long-term care or in the community? And if in long-term care, is this because they don't have the necessary equipment to support the client resident?
Yeah, so we didn't ask our participants that question directly. We did ask them to compare lift assist calls from the community versus long-term care. And they identified that lifts in long-term care were sometimes easier because those facilities were kind of designed with interventions in mind. So being able to move a bed because it's on wheels and there's more space available versus in home, you have to kind of deal with whatever situation you're faced with in the community. A study in London, Ontario from 2015 found that 5% of the lift assist calls were from long-term care, but that number was increasing with the aging population. Part of why long-term care did call for the lift assist was they don't have the equipment available. The large mechanical lifts that they have limitations due to the space required to use them. So if the device isn't able to be used, if they can't use their large mechanical lift, to comply with the zero lift policy, which is common in many homes, they would need to then call EMS to complete that lift. Part of why long-term care, it was only 5% of calls in 2015. Again, that number is expected to increase. But part of why that's a bit of a focus is it's an easy place to intervene where healthcare practitioners are already there. So if they do have access to the proper tools, they could perform the lift to decrease the burden on EMS, where we can't necessarily give people tools at home to stop falling. The occupational therapists on the falls intervention team try to, but it's hard. We can't get people to stop falling and lift themselves if they do experience a fall. Whereas in long-term care, since those healthcare professionals are already there with the proper tools, the lifts could be dealt with internally to decrease calls to EMS.
Thank you so much, Amanda, for your thoughtful and motivating presentation today. It's such a big topic of interest, and hence why CRE-MSD has a community of practice dedicated to client-patient handling. So thank you, and thank you to all of our participants who have joined today. And again, encourage all of you to watch the CRE-MSD website and the MSD prevention site for more information on client-patient handling. And for all of you, we encourage you to join us October 3rd to kick off Global Ergonomics Month. CRE-MSD is hosting a free in-person conference in Mississauga on manual handling, where exoskeletons fit within the musculoskeletal disorder prevention strategies. And our registration opens on August 19th. Thank you all for joining us, and have a wonderful rest of the day.